Welcome to PCR London Valves 2025. It's my great honor to be here with a couple of good friends that I had a chance to be on an amazing session, Dr. Michael Borger and Joao Cavalcante. We have this great session about aortic insufficiency and how we need to look at it from a different perspective beyond the regular TAVI field, all right? And you gave a fascinating talk, Joao, that essentially set the stage about the disease and why the disease is different. What is different about aortic insufficiency compared to the mainstream aortic stenosis cases that we see on a daily basis?
Yeah, I mean, even though we're starting to talk about the same valve, but the pathology that leads to aortic regurgitation is very different. So it's a disease of the supporting structure of the root, of the leaflets. Leaflets can be calcified. Sometimes they can prolapse. Sometimes the SCJ is effaced. All of that will lead to aortic regurgitation. Because of that disease variability, the jet that we typically will be looking at from the echocardiogram perspective can take different directions. And if you're not facing the jet in front of you, you're going to be underestimating. And that leads to another problem.
So you said something very interesting that caught my attention, but you said we need to go beyond moderate. We cannot just stop there and just say, okay, the patient has moderate aortic insufficiency. We need to actually be more comprehensive and thoughtful with those patients. What do you mean exactly with that?
Yeah, no, I think that is a reality that we see, right? These patients, by the time they come to Michael, they're already far remodeled. It's question moderate. What I wanted to have as a take-home message from this meeting is don't sit on moderates. Prove that it is moderate, because sometimes they could be, but in most of the time, 40–50%, you might be finding that there is already LV remodeling and it is severe, and we're just under-calling. And this under-calling comes at a huge price. The patients don't get presented at the heart team, they don't get operated.
That's very interesting. So Michael, going into the surgical field, all right, why is actually aortic insufficiency different compared to, again, mainstream aortic stenosis patients?
Well, surgery still, as you saw in the 2025 ESC, EACTS guidelines.
It is gold standard.
We're just presented. It is gold standard, but there are a lot of patients that are elderly and higher risk and are not good surgical candidates. And in those guidelines, we made a couple of new recommendations or revised recommendations that I think are really applicable to these patients. There is sort of a bimodal presentation of patients. There's the young ones, oftentimes with bicuspid aortic valve, that can withstand surgery and can get a good result of that. And then there's the elderly patients where somebody may be sitting on a moderate AR for a long time, and then they can present even too late in their disease process. So we have to look for cardiac damage with advanced cardiac imaging modalities, especially CMR, and look at the volume and index it to the patient's body surface area. And then if we say, okay, this is severe AR, then surgery if they're surgical candidates, and we actually even have a 2A recommendation now for aortic valve repair, but it requires the local expertise. And then for those patients that are not good surgical candidates, we now have this 2B recommendation for TAVI if the anatomy is suitable, using preferably dedicated devices.
But one of the things is, you as a surgeon, what do we need to learn from you in terms of when we're putting these devices in these patients? What would you say, be careful with this? This is a different entity that you are not really used to.
Well, one thing I would say, even before the intervention team, is to people watching here, is to make sure you don't wait too long. Yeah. Oftentimes with especially eccentric AI, it can be under quantified for a long time. And I see as a surgeon quite often patients come in with these huge dilated ventricles with a decreased EF, and that has a very negative post-intervention effect on their survival. So we have to intervene earlier, and I think we're quite clear in this in the guidelines. Then once they do come to us, we always have to look at the aorta. If the aorta is enlarged, then we do a surgical intervention that addresses both of those issues, and if it's a younger patient, a valve-sparing root replacement is what we recommend as a class 1 recommendation. But if there is no aortic aneurysmal dilatation, then surgery, which would be usually aortic valve replacement, or the higher risk ones, transcatheter But we do have to, of course, take into account they don't have calcification. You can't see the valve well on fluoroscopy. They oftentimes have large or very elliptical annuli, and therefore we also suggest these dedicated devices for this pathology.
So take-home message, when you have a patient with aortic insufficiency, for our audience, it's a different type of disease subset. It's not just mainstream aortic stenosis. Good imaging, good evaluation. Don't settle if it's moderate, go beyond and do a very comprehensive evaluation. Talk to your surgeon to actually explore the options, and ideally go with dedicated devices instead of actually off-the-shelf devices, which I think have to be done in the experienced hands to be able to do TAVR with regular devices in these anatomies. Again, thank you for allowing me to interview you. It was a phenomenal topic, highly relevant, that actually happened here at PCR London Valves 2025.